good morning, good afternoon, and good evening to all speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for the first section of today is our honorable guest from Japan, Professor Masahiko Tosaka. Professor Tosaka is the Vice Director in the Department of Hypothalamic and Pituitary Surgery at Toranomon Hospital in Japan. He was a previous fellow at the Department of the Pituitary and Skull-Base Surgery at the Ohio State University. His clinical interests are focused on management of pituitary tumors, brachycephalus, craniopharyngiomas, tuberculum septum meningioma. He has also conducted research activities focusing on endoscopic and nasal surgery and diagnostic imaging of the hypothalamic and pituitary lesions. And we're extremely honored to have him today at our webinars. And today he will be talking about the fascial patchwork closure with deep suturing technique after endoscopic and nasal transsphenoidal resection of the tumors. The speaker of the second section of today is our honorable guest from China, Dr. Pang Ya. He is a neurosurgeon of the Department of Surgery of the First People's Hospital of Changzhou, the third affiliated hospital of Suzhou University. He is a member of the standing committee member of the Chinese Federation of Interventional and Therapeutic Neuroradiology. He also serves as a chair of Jinshu Society of Neurointerventional Surgery. We're extremely honored to have him today at our webinar, and today he will be talking about Serpentine aneurysms of the ACNS. The chair for the first session of today is our honorable guest from Indonesia, Professor Julius Julai. Professor Julius is a senior neurosurgeon neuroscience service at the Serpentine Hospital. Professor Julius was a member of the Indonesian Medical Association, Indonesian Society of Neurosurgery, Indonesian National Brain Foundation, international member of ACNS, and international member of CNS. He was a previous neuro-oncology and skull-base fellows at the Toronto Western Hospital, as well as neurovascular fellow at the Fujita University Hospital in Japan. His clinical interests are focused upon neurovascular surgery, skull-base surgeries, and neuro-oncology. We're extremely grateful to have him for accepting our invitation to chair the first session of today's webinar. The chair of the second section is our honorable guest from Japan, Professor Kimura. Professor Kimura is a consultant neurosurgeon in the Department of Neurosurgery at the Kobe University School of Medicine in Kobe, in Japan. His clinical interests are focused upon cerebrovascular neurosurgery, especially bypass and aneurysms. He is an integral part of the ACNS delegations to various countries over the years for workshops and conferences. We're extremely honored to have and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of ACNS and the President, Professor Yoko Kato, I'd like to welcome both the speakers and the chairs and the audiences to this online platform of ACNS webinars. And a very warm welcome to our colleagues in China. We're extremely thankful to Professor Shubin for broadcasting the webinar on the WeChat channel. And Dr. Liu Bun Singh from Malaysia is my co-host today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Julius.
Thank you, Dr. Ben, for kind introduction, and also thank you, Dr. Raja, and especially thank you for Professor Kato for kind invitations for me to chair these first sessions. Greeting from Indonesia to everybody. First sessions, as we know that Professor Tosaka is quite well known for doing delicate suturing in a small corridor after the skull-base surgery through transsphenoidal. I have listened to his talk for many times, but I still always, every time I learn something from him. So I think we are looking forward to learn something new from Professor Tosaka. So Professor Tosaka, time is yours, please.
Thank you. Thank you. I would like to thank Professor Jurai, Professor Jurai and Professor Ben for kind introduction to this lecture. And I'd like to thank Professor Raja for the kind management to this lecture. And also, I would like to thank Professor Yoko Kato for giving me this opportunity to present my study. Today, I will talk about deep suturing techniques in endoscopic and nasal transpenoidal surgery. This is my COI disclosure. I will follow this agenda: A. Introduction, B. History, C. Basics of deep suturing, D. Training. After the removal of a pituitary tumor via transcerebral pituitary surgery, Hardy's operation, membrane structures such as the diaphragm zere, arachnoid membrane, and the normal pituitary gland remain. And in this case, we can stop intraoperative CSF leakage simply by filling the cellar with an abdominal fat graft. However, expanded endonasal transsphenoidal surgery involves direct access to the subarachnoid space, which requires a watertight closure to prevent CSF leakage after tumor removal. In the well-known Exposit grading system for CSF leaks, all CSF leaks after expanded transsphenoidal surgery are classified as the highest grade, grade 3. In the skull base, reconstruction is not robust. The patient can easily develop meningitis and or encephalitis, which can be very dangerous. The endonasal expanded transsphenoidal approach to the intradural skull base lesions was not performed for a long time because skull base closure techniques were not well established. A revolutionary breakthrough occurred in 2006 with the discovery of the nasoseptal flap, which made it possible to completely seal minor CSF leaks. Since the discovery, there has been an explosion of advances in the technique of expanded transsphenoidal surgery, and this procedure is performed worldwide now. Here is a video showing us creating the nasoseptal flap. In this video, nasoseptal flap is made before the approach, and other times it is created as a rescue flap when needed. In this video, the nasoseptal flap was placed in the corner and the procedure continued. Here, the technique of skull-base reconstruction is central to the overall surgical strategy of expanded transsphenoidal surgery. This review paper ranks the reports that have had the greatest impact in this field to date. The paper on the discovery of nasoseptal flap was ranked first. Currently, the multiple layer closure method and the gasket seal closure method, which are used worldwide, enable robust watertight reconstruction of the skull base using the nasoseptal flap. The yellow dotted line indicates the nasoseptal flap, pellicle flap. The left figure is gasket seal closure. The right one is multiple layer closure figures. I'd like to talk about the history of skull-base reconstruction using deep suturing technique. Attempt to close the dura using suturing technique after endonasal skull-base surgery have been reported since around 1990. Yang et al. Reported on closure by suturing after what is now called the expanded transsphenoidal approach in a cadaveric study. They first invented the knot tying method in the deep endonasal site, described an early node pusher and was the first to demonstrate the patch graft method using Fascial. Early expanded transsphenoidal surgery was performed using a microscope in 1997. Mason removed a suprasellar small pitonet via expanded transsphenoidal approach. However, the skull-base reconstruction procedures were not described in detail in this report. An early paper on the transsphenoidal transtuberculum zeta approach published the following year in 1998 from Japan described the procedures as follows. The dural window is packed intradurally with a fat graft, and closure is further accomplished by the insertion of bony graft from the removed septum between the dura mater and the tuberculum zeta. In Japan, Professor Kitano et al. Introduced a deep suturing technique under a microscope after expanded endonasal tumor removal, 2001. They described that the dural window is patched with Fascial and sutured with number 50 nylon in a watertight fashion. The Professor Yamada et al. From Toranomon Hospital in Japan also reported using a deep suturing technique for skull-base closure under microscope. They described that after tumor removal, large dural defects were patched with Fascial from the right quadriceps and sutured with 60 nylon in a watertight manner, following by packing of fat tissues and prepared autologous fibrin glue in the remaining sphenoidal sinus. During the same period, Professor Kim et al. From Yonsei University in Korea also reported on the use of deep suturing technique under the microscope. They provided detailed guidance on the best tools and techniques for moving the suturing nodes. Since then, several studies have been published on performing deep suturing in expanded transsphenoidal surgery. This series of reports focused on expanded endonasal transsphenoidal surgery using the deep suturing technique. Nearly all of these reports originated from Japan. Since 2015, Fascial patchwork closure using an endoscope has been introduced. A multi-layer strategy combining Fascial patchwork and nasoseptal flap has been implemented. One example of typical multi-layer closure, including Fascial patchwork, outer layer fasciolata, and the nasoseptal flap, was presented by Hara and Akutsu in 2015. They used around 5 knots for Fascial patchwork closure. In 2019, we reported on 28 cases where patchwork closure was performed using the deep suturing technique without the use of nasoseptal flap. Our findings indicated that CSF leakage occurred in only 2 cases. This report was the first to provide a detailed description of the deep suturing method, which has become a foundation for young pituitary surgeons in Japan to learn suturing techniques. We would like to share some insights from this paper. Now I will discuss the basics of deep suturing. First, I will present a short video summarizing deep suturing using Fascial. In our typical surgical reconstruction following and nasal endoscopic removal of craniopharyngioma, we place approximately 10 to 11 sutures to complete the patchwork suturing using Fascial. Next, I will introduce the basics of deep suturing following this agenda. Our endoscopic system, suturing tools, various needle holding methods, various not moving methods, in-layer suture, in-layer structure, representative cases. Let me introduce our endoscopic system. During the period from 2015 to 2019, we used a system with an Olympus end arm. The endoscope is fixed to floor-standing pneumatic-powered endoscope holder. We also used the Uniarm system by Mitaka in the same way. In general, for transnasal skull base surgery, the endoscope is typically held by a scopist, which is the most common approach. However, the floor-standing holder system became quite popular in Japan because it was available at an early stage. We performed surgery using both the Olympus end arm and the Mitaka Uniarm systems. We compared the advantages and disadvantages of the scopist held style versus the holder system. The advantages of the scopist holding style: one, three-dimensional sensation from the movement of the endoscope. Two, the scopist can easily adjust the field of view. Three, it allows the use of 3 or 4 hands technique. 4, provides consultation opportunities for intraoperative decision-making. Disadvantages of the scopist holding style: 1, requires 2 surgeons, including endoscopist. 2, there is a potential for interference between the surgeon's hands. 3, the endoscope's movement is relatively limited. Advantages of the holder system: 1, allows for fine manipulation. 2, requires only 1 surgeon. Disadvantages of the holder system: requires an endoscope holder. 2, provides a completely 2-dimensional view. 3, the system can have strong interference and requires a learning curve. In surgeries where the scopist holds the endoscope, the surgeon benefits from a 3-dimensional sense due to the slight movement of endoscope. This also makes it easier to obtain close-up images. On the other hand, in surgeries using the endoscope holder, the surgical field remains completely stationary, resulting in a 2-dimensional view. This can be difficult to manage unless you are used to it. However, the advantage of being fully fixed is that it allows for very fine and precise movements. For our endoscopic and nasal surgeries, we use the floor-standing pneumatic-powered endoscopic holder system. I'll talk about suturing tools. As basic tools, you will need a needle holder to hold the needle and a knot pusher to move the knot. Figure A shows the deep suturing needle holder without a latchet. The top of the holder is angled upward by 45 degrees and the effective length is 170 millimeters. In figure C, we used alligator forceps to handle the needle. These forceps are one of my most frequently used tools and are very effective. They have a 30-degree upward angle and are 180 millimeter long. Both the needle holder and alligator forceps are more effective with angled tips, as this makes it easier to see the tips of during surgery. Figure B displays the knot pusher we use. It is very simple type of knot pusher designed for ease of use. Various needle holding methods. There are three main ways to hold the needle during surgery. The first is the tandem hold, where the needle is held parallel to the holder. In panel A, the needle tip faces the same direction as the holder, which we refer to as the moderate holding angle. In panel B, the needle tip faces toward us, which we call the acute holding angle. This acute angle is frequently used in endonasal surgery. The second method is the regular hold, where the needle and the holder are perpendicular to each other, as shown in panel C. Occasionally, we also use the oblique hold, shown in panel D. In the tandem hold, the angle at which the needle is held can be adjusted in various ways. During suturing, you may need to change the holding angle depending on the situation. We call this the holding angle changing technique. In this figure, you can see how we change the holding angle from a moderate angle, panel A, to an acute angle, panel B, for endonasal deep suturing. As you can see in this video, we changed the holding angle from moderate angle to acute angle to perform endonasal deep suturing. First, needle was inserted into fascial with moderate angle of insertion. Subsequently, the needle was advanced into surrounding dura with change to more acute angle of insertion. In the regular hold, you hold the needle either on the left or right, as shown in panel C. In panel D, in the downward oblique hold is frequently used, which we call the sickle style. The video demonstrates the regular holding style and the reverse regular holding style, reverse regular. And this is the real deep side of the sphenoid sinus. Additionally, the oblique holding style is sometimes used, which you can observe in both the left and right sides of the video. This is the holding style, oblique holding style. This is reverse upper oblique holding style. And this is the sickle style. The lower oblique style, and we can see the top of the needle easily in this sickle style. And next, we will demonstrate how to move knot created outside the deeper, various knot moving methods. We will introduce sliding knot technique, single or double knot sliding technique. We have developed a new and simple knot sliding method. First, create a knot outside the nose. By pulling one of the threads, the knot can be easily moved deeper into the nose in panel A to C. Next, we will show the double knot sliding technique in panel D to F. We can move these two knots to deeper by pulling one of the threads. We can call this double knot sliding technique. And you can see the simple knot sliding technique in the video demonstration performed on the model. By pulling one of the threads, the knot can be easily moved deeper. Well, we can move simple knot. Next, we will show the double knot sliding technique. We can also move these two knots to deeper by pulling one of the threads. The double knot sliding technique. The pulling, usually deep knot are created 3 times. This single and double knot sliding method cannot be used for the last knot, so a knot pusher is used. The video shows the hand movement outside the nasal cavity during suturing. The first knot was made by sliding knot technique. The second knot was moved by knot pusher as a screw fashion. And after that, third knot was pushed by a knot pusher with a screw fashion. We use a very simple shape knot pusher. However, knot pushers of various shapes, such as the Dr. Amano's knot pusher, can be available. It is a good idea to try different types of knot pushers. Of course, curette in pituitary surgery can also use for this purpose. When the thread gets caught in the nasal cavity, we sometimes perform direct tyings of sutures at deep side of the nose. In this case, it is important to adjust the length of the threads accordingly. One of the threads should be long, and the other of the threads should be short. And then make a knot directly in the deep side of the front sinus. Inlaid suture, when using fasciculata in an inlayer suture is required structurally. In 2004, Professor Kitano demonstrated the need for inlayer sutures. For watertight suturing for CSF, the outlayer materials were structurally weak. The first, the needle is passed through the fascicle twice in panel A and then through the dura to create an inlayer suture. This is panel D. The fascicle should be positioned in an inlayer fashion. We recommend using patchwork sutures on the inlayer fascia followed by a rigid material to suppress the pulse waves of the CSF. This CSF pulsation can cause the thread to come undone. Fixing the central part of the bone window is crucial, and at least a bridge-like hard structure is recommended for this purpose. The bone of the nasal septum is ideal, but it may be too thin to harvest. In such cases, a bridge made of hydroxyapatite can be used. Panel H showed the use of hydroxyapatite plate to suppress the pulse waves of the CSF. The order of suturing may vary. If the size of the fascia is just right, it can be sutured randomly. Some surgeons began by performing diagonal sutures first. If the size of the fascia needs to be adjusted, suturing is done from front to back. If the fascia is too large, it can be trimmed and adjusted. In present a representative meningioma and craniopharyngioma cases, the typical case of tuberculum zere meningioma, a 74-year-old woman presented with decreasing visual acuity. Preoperative Goldman kinetic perimetry showing light visual field defect. The preoperative best corrected decimal visual acuity was 0.6. The logMAR equals 0.2 on the right side and 0.9, logMAR 0.1 on the left side. Preoperative T1 weighted MRI after injection of gadolinium demonstrating a small tuberculum zere meningioma with diameter of 1.7 centimeter on the sagittal section. The tumor had invaded the right optic canal. The patient had hoped for endoscopic transsphenoidal removal of the tumor rather than craniotomy. The skull-base dura was opened and the whitish tumor was presented. The tumor was very soft and we can remove it easily by suction. The ACOM complex and pituitary stalk, optic nerve were confirmed. Dura of the optic canal was opened. The tumor piece was removed using suction. Removed by suction. And this dural attachment of the tumor was coagulated carefully. We confirmed the internal carotid artery and the starting point of the ophthalmic artery. Then we can see the optic nerve and the pituitary stalk. After the removal, patchwork suture was started at the optic canal. The fasciolata was thinly and carefully sutured to prevent the mass from compressing the optic nerve within the optic canal. We use the holding angle changing technique at the anterior side of the dural window, and this is a regular holding style at the posterior side of the dural window. Regular holding style. And using node pusher. Anterior side tandem hold and holding angle changing technique was used. The regular hold at the posterior side of the window. And we confirmed the watertight suture by Valsalva method. The hard plate was placed for suppressing the CSF pressure. The postoperative Goldman kinetic perimetry showing the same visual field but with better visual acuity. The postoperative best corrected decimal visual acuity was improved to 0.8 logmar 0.1 on the right side and 1.2 logmar minus 0.1 on the left side. Postoperative T1 weighted MRI after injection of gadolinium demonstrating total resection of the tumor. Next case is craniopharyngioma case. Deep sutures are more useful in craniopharyngioma than meningiomas and pituitary neuroendocrine tumors. Because deep suturing requires the dural seam allowance to be intact. I will introduce a representative craniopharyngioma case as case 2. A 42-year-old man presented with rapid deterioration of visual function, mild disturbance of consciousness, and hypopituitarism. Preoperative Goldman kinetic perimetry showing a visual field defect by temporal hemianopia. The preoperative best corrected decimal visual acuity was 0.4 logmar 0.4 on the right side and 0.07 logmar 1.2 on the left side. Preoperative T1 weighted MRI after injection of gadolinium demonstrating a large cystic supercellular tumor with diameter of 3.0 centimeter on the sagittal section and preoperative diagnosis of craniopharyngioma. The patient requested transnasal endoscopic tumor removal. We removed this tumor via expanded transsphenoidal approach. We use deep suturing technique for stopping the bleeding from intracavernous sinus. Right side and left side, we make a knot at the intercavernous sinus. And whitish tumor was dissected from surrounding structures and removed carefully. The tumor was carefully dissected away from the optic chiasm. The dissection between the tumor and the optic chiasm is important technique. And tumor was removed piece by piece, sometimes with scissors. And the main mass was removed by suction. The small tumor piece was removed from the bottom of the third ventricle. And this is in yes. After tumor removal, fasciculata was harvested. The center and edges were marked with a blue pen. The angle of the needle tip was carefully adjusted while suturing. And this is a knot sliding technique. And after that, we use the knot pusher. And anterior side, we use the angle changing, holding angle changing technique. And after that, this is a automatic sliding technique. After that, we use the knot pusher. And holding angle is very important. And we frequently adjusted the holding angle and make a stitch. Holding angle is very important. Now, after making 21 stitches, fibrillin glue was applied. After Valsalva test, we judged not to use rescue nonseptal flap. 21 stitches. The postoperative Goldman kinetic perimetry showing improvement of bitemporal hemianopia. The postoperative best corrected decimal visual acuity was improved to 1.2 logmar minus 0.1 on the right side and 1.2 logmar minus 0.1 on the left side. The postoperative T1 weighted MRI after injection of gadolinium demonstrating total resection of the tumor. We basically use this fascial partial closure with or without nonseptal flap for the all craniopharyngioma cases. No patient have developed meningitis and postoperative CSF leaks are rare. And finally, I will discuss the training system for the deep suturing technique under endoscopy. Training is crucial factor in mastering this deep suturing technique. This chart shows the suturing time for fascial patchwork closure, comparing 11 cases from the early period and 24 cases from the later period after 2017. The mean suturing time was significantly reduced from 100 minutes before 2017 to 78 minutes after 2017. The shortest suturing time was achieved in the most recent case in 2019 with 39 minutes to place 15 stitches. This time includes the period spent searching for a lost needle, which would significantly increase the overall suturing time. The shortening the suturing time through training is very important. Recently, it has become possible to practice using a simple endoscopy set in the dry lab. This set uses a syringe to recreate the narrow space inside the nasal cavity. This tabletop remaining system, a training system, is very useful for practicing deep suturing. Additionally, experience with suturing during cadaver dissections would be highly beneficial. It is a good idea to first practice deep suturing in intracellular pituitary surgery, especially Hardy's surgery. This was the first time that Nishioka International Hospital et al. Demonstrated suturing techniques for routine pituitary surgery in 2009. Only 1 or 2 stitches are required to achieve a robust closure. And fat closure is also applicable for skull-base closure. Takeuchi et al. Reported technique for closing the dura mater in shoelace-like fashion using fat, which is a very effective method for expanded transsphenoidal removal of the tumor. Adding such dural sutures to a multi-layer closure method using fat may enable an even more robust closure. This is the last slide summary. The skull-base deep suturing technique is very useful in endoscopic and nasal surgery for various intradural regions. In expanded transsphenoidal surgery, especially the transtuberculum zere transplanum approach, it is possible to perform deep suturing closure without using a nasoseptal flap. The deep suturing technique will continue to evolve, and we believe it will enable even more robust skull-base reconstruction, contributing to safer surgeries. Thank you for your attention. Thank you.
Thank you, Professor Tosaka. Very delicate skill, and even for you, very experienced surgeons, it require at least 5 to 7 years to reduce the time from starting doing the suturing and a narrow corridor to actually at least half or 1/3 of the first time you're doing it. If I may have questions, do you ever try using a synthetic graft to do the suturing instead of the fascia? And I would like to know your opinion. Thank you.
Synthetic, I'm sorry. The other materials?
Yes.
Yeah, we always use Fascial. Fascial. Maybe in ancient period before 2000, the various materials are tried to use for usual pituitary surgery, Hardy's operation. In that period, then the abdominal fat graft and Fascial and muscle was tried. Then I use this now I use this information, but Duragen is a good material, and I hear that the other my friend use Duragen and suture the Dura and Duragen and stopping the CSF leaks. But in my experience, and it may be slightly not sufficient for robust reconstruction in the skull base dural defect, maybe.
Okay, thank you. Because I also use inlay just Duragen and also the vascularize the nasoseptal flap, and just that's it. I think it's also one of the technique that some of the skull base surgeons using it. Maybe Dr. Ben have questions, Dr. Ben Ang? Please, Dr. Ben.
Yes, and very impressive lectures. And first of all, thank you so much about this technique, and it's awesome to see how you learn it and how we can do it. And for me, I'm doing the same way with the Professor Julius. So I'm using the laser-septal fab and also the inlay dual joint with abdominal flap graft. So I would like to ask about your opinion. So I saw that in your case, you after suturing and you put it the hydroxyapatite, and then there's no leak for the nasal septal fab. But at the beginning, when you start doing this technique, do you still use the nasal septal fab to do this?
Flat?
Yeah, flat. Nasal
Yeah. Maybe half.
When you started.
Yes, thank you. Thank you very much for your good question. And in this real experience, I maybe in the meningioma case, tuberculous meningioma case, the seam allowance is invaded by meningioma, and we cannot sew the to the intact dura. The dura is invaded by tumor. The same thing is in PitNet. And very high-aged patient. Intact seam alliance is key for make a stitch to deep side for us. Then the half of the expanded transperineal surgery was surgery. We performed the dural suturing in the deep side of the nasal dural window using nasoseptal flap. The half patient is not needed for flap, especially in craniopharyngioma case. The craniopharyngioma is originated from stroke, and dural seam allowance is intact, and we can make a stitch easily.
Yes. Yeah, and my second question is about like after you suture the fascial lateral flap. So how do you challenge that it is a watertight closure? So you challenge it by a Wasafa maneuver at what pressure? So how can you make sure there's a low water is watertight?
Challenge.
Challenge.
Yeah. Maybe yes, nasoseptal flap is not so good for a patient because the embedded situation in nasal cavity. Then my challenge is trying robust suture without nasoseptal flap. In the tuberculous difficult case, we make a stitch, and after that, sometimes we use abdominal fat, and sometimes use bathtub method. We use a combination of these CSF stopping method and perform the robust skull base closure without nasoseptal flap. That may be our challenge.
Thank you. And about like how do you ensure that it is watertight? Maybe
watertight. The Valsalva method. Valsalva. Valsalva. Yes. I should use the Valsalva method.
Okay. How much the pressure? How much pressure for the Wasafa?
Pressure 20 centimeter.
Okay.
20 centimeter. Yes.
I see. So I'm sorry, I have a last question, like for those do you have for example, for those meningioma case, so sometimes the lateral dura on the both sides is very close to the cavernous sinus wall or the ICA. So how do you do that? The dura is very close.
Yes. Dural limit is wall of the CSF, and cavernous wall is very stopping the cavernous wall is very important because the breathing is dangerous because
Yeah.
cameras we make a wall at the level of dura. The cameras breathing go into the brain, go into the subarachnoid space. That is very dangerous. Then we
Yes.
should stop the camera sinus breathing robustly. And after
see.
that, we close the dural opening with Fascial fascia closure or using the abdominal fat graft. That maybe stopping, yes, stopping bleeding is important for camera sinus. Using bubbles like coagulation kit, maybe bubble. Bubble or the other materials and stop the breathing from camera sinus is very, very important for us.
I see. I see what you. Thank you. Thank you so much.
Okay. Any more questions from the floor? Do we have more questions? Maybe one last question, Professor Tosaka. Since you have a lot of number, but with single material with this fasciolata and also suturing, do you plan to do a comparison study with other technique and method with another center? For example, in center that use more simple technique without suturing, using inlay Duragen and also nasoseptal flap only, or even some with fat, and then compare the result. I mean, the result of the complications, the result of the CSF leak, the result of many other things. Do you plan to do that? Thank you.
Thank you. Then, yes, that may be the Japanese tradition to make suture in this region. And maybe the all papers are all past papers indicate published from Japan only. And maybe the Korean neurosurgeons use maybe stitch stapler like stitch to
Similar with
yes, that means maybe very good good tool to stop the but they use maybe fasciolata, but this stapler like instrument is very good for this purpose. And that in my paper, I submitted this paper. The reviewers said that the other material. What do you think about the other materials? That is very good idea for future. But now Japan, I'm under Japanese tradition to use the suturing technique in deep side of the nose. But in the future, I will think about these new materials and new methods and new tools to stop the CSF leakage at the deep side of the skull base, nose, deep side of the nose. Thank you.
Yeah. Thank you very much, Professor Tosaka, for a very insightful lecture and also sharing with a very delicate skill So we also should follow your step maybe in the future. For this time, I think we close these sessions. Thank you very much. I pass it back to Dr. Ben Ng for the next session. Thank you very much.
Yes, thank you so much. This is a very excellent section. So maybe shall I invite our Chair, Professor Kimura?
Hello everyone, I'm Hidehito Kimura from Kobe University, working at the Kobe University. I treat mainly vascular region and skull-base region. So usually my usually surgery is a clipping, the bypass, and AVM and something like that, and some of course skull-base region. So today I will invite Professor Pena. He will talk about serpentine aneurysm of the ICA and MCA surgery. So as you know, it is in the serpentine aneurysm. So even in the endovascular area, so it is very difficult and challenging region, even using the open microvascular technique or also endovascular techniques. So he will talk about the cutting edge technique for this difficult, challenging region, ICMCA, serpentine aneurysm. So Professor Pena, so please start your presentation if you are ready. Thank you.
Okay. Thanks to Professor Kimura for your introduction. And hello, everyone. Dear leaders and friends, I'm Dr. Peng. Yes. Firstly, I would like to say thanks to Professor Bing Xu inviting me to take part in this program. It's my great opportunity to have this chance to share something with all of you. I'm a neurosurgeon, and also I'm a neuroradiologist. I started aneurysms, AVMs treatment from clipping, then to calling. But now most of aneurysms in my center are embolized. Today, my topic is to do or not to do a case of an internal carotid artery, middle cerebral artery, serpentine aneurysm. Serpentine aneurysm is a rare type of intracranial aneurysm with unique image and pathological characteristics. This kind of aneurysm is partially thrombosed giant intracranial aneurysm, always with a diameter more than 25 millimeter. An eccentric and tortuous vascular channel in this kind of aneurysm, and the inflow and outflow tracts are separated. The exact pathogenesis is not very clear, but most widely accepted theory is that cystical aneurysm continuously extends into a serpentine structure known as the coendo effect, which is a fluid dynamics phenomenon. The common pathological instance is the dynamic process of thrombosis and aneurysm formation. The clinical symptoms are often related to the local mass effect of the partially thrombosed giant aneurysm. Up to 30% of patients present with aneurysm rupture and subarachnoid hemorrhage. And some people suffer ischemic stroke. So the treatment of serpentine aneurysm is tough and full of challenge. It is difficult to completely clipping, and surgical bypass or endovascular treatment may be considered. But the treatment plan needed to be carefully formulated, case by case. So I will show this case. This is a female 40 years old, admitted for headache with nausea and vomiting for 2 hours in 2022. Examination, Huntington's 2, grade 2, GCS 15. Neck rigidity, no other neurological signs. CT shows semirectal hemorrhage. When I looked at this CT scan, I tried my best to look for a familiar image in my memory. And time going back to 2019, 3 years ago, a high-density mass was discovered on CT due to headaches. This woman, when she was 45 years old, CTA shows a dissection aneurysm with calcification in the vessel wall. And MRI T2, TOF, and MRA and SWI revealed a high tortuous dissection aneurysm, showed no thrombus in aneurysm body. Cerebral angiography confirmed right ICA2 MCA dissection aneurysm with a long and tortuous lesion, which we can call it serpentine aneurysm. And some branches like lenticular straight artery, anterior caudal artery, and pecum artery arise from the aneurysm body. Several small baby sacs around the body. And we can't see any collaterals from the right ECA, left ICA, or posterior circulation. And 3D angiography and 3D reconstruction showed this serpentine aneurysm extended from the distal of the ophthalmic artery to the M1 bifurcation. The lesion of the aneurysm was incredibly tortuous with several baby sacs and branches such as pecum, anterior caudal artery, and perforating artery arranged from this body. So it looks very, very, yes, it's difficult to be treated. And we use AI technology to assess this rupture risk. This AI software called Aneurysm. And we use this AI to assess the rupture risk by wall shear stress, and oscillatory shear index. The point was this SIG1 and SIG2 and SIG3 from the proximal of the aneurysm distal to the M1. And you can see the first level is rupture risk assessment based on morphology, and the second level is rupture risk assessment based on hemodynamics. And this is rupture resemblance score. And the 3 sacs are all in high risk of rupture, especially SIG1. So this patient's diagnosis is right internal carotid artery, middle cerebral artery, serpentine aneurysm. How about the treatment? What can we do, and what should we do? Maybe one of the choice is stent assisted calling. with multiple stents, and how can we save the perforating branches? How to coil the sac? The second choice is flow diverter, but depend on the aneurysm's length, tortuosity, vessel diameter. It's challenging for flow diverter application. And maybe bypass, ECA to ICA bypass, but high or low flow. And we still afraid of ischemic stroke after bypass. Do nothing, just follow up. And other options, just like hybrid surgery. Maybe we can do bypass and occluded the clinoid of ICA. And two-stage surgery. First bypass to establish the collateral compensation. 2 or 3 months later, clipping or coiling the distal ICA of ophthalmic artery. So indeed, I didn't have any confidence to do any intervention or surgery. And also, I didn't have any reason to convince this 45-year-old female at any risk of complication, even the aneurysm was high risk of rupture. So at that time, maybe follow-up is the best choice. In 2020 and 2021, follow-up CT showed the aneurysm was stable. The woman enjoyed her life and did everything she wanted. However, just when I was waiting for a follow-up of the third year, I got the unexpected result of bleeding. It brought me back to the harsh reality. The aneurysm ruptured, but the patient was not very serious with Huntington's grade 2. So in the next morning, we did angiography. The 3D showed the serpentine aneurysm became more tortuous and looked more aggressive. At that moment, few options left for her and me. So we have to choose stent-assisted crawling, hoping to use a long stent to reconstruct the vessel and use coils to embolize the rupture point. And because of the acute phase of bleeding, so we use tirofiban to be antiplatelet strategy, and with a dose of 5 milliliter and intravenous maintenance. So micro-wine was navigated through the channel of the aneurysm, and Prolaplus microcatheter was reached the distal of the aneurysm to put the long stent. Because of the tortuous and angle, even the echelon 17 was shaped like ace, but it was failed to get to the sex 3. So we put the microcatheter in the start of the sex 3 and sex 2 to calling the beginning of this sec. After the calling the sec 1 the sec 3 and sec 2, withdraw back the microcatheter to the second one and use some large coils to fill the second one. After embolization, the aneurysm looks calling well, and we can see some even the rupture point maybe with no calling, but we can see the retention of contrast. So the risk of rupture was very low, and we can see after operation angiography shows the reconstruction of the long vessel and the package of the coiling of the coils. But 6 hours after surgery, the patient developed a state of delirium and with right gaze and the left limb strength lost to grade 3. Emergency CT shows no rebleeding. So we think it's an ischemic stroke, and MRI confirmed a scattered flash infarction in the right cerebral hemisphere in DWI and ADC. So tirofiban maintenance for 36 hours, then replaced by aspirin and Plavix. And the 5th day after surgery, TEG shows AA 100% and ADP 100%. So the antiplatelet is aspirin 100 milligram and Plavix 75 milligram for 3 months, and then aspirin 100 milligram for 3 months. 10 days after surgery, CT revealed a very small infection in the right lobe, and the patient recovered very well and was discharged. Half a year later, the patient was very well and followed up by angiography. The clinoid of right internal carotid artery was occluded. We think is a chronic occluded. There were collaterals from the left side from ACOM, and which can reach to the end of the M1 and the bifurcation. So, and also we can see collaterals from the post circulation by the inferior temporal artery. And in 2023, 2 times MRI follow-up, the patient was very well, and with the right ICL occlusion, even with the ICL occlusion. So the patient is very well. Although this case looks success, and the patient recovered very well, but still some questions. First, is non-doing the best choice in 2019 before the aneurysm bleeding? And is it appropriate to treat after bleeding? It seems we are safe, but we leave the dangerous to the patient. And after follow-up, is the chronic occlusion of the ICA the best cure? And if the aneurysm reopen on follow-up, what can we do? We use FD or do surgery? what makes good outcome? The patient, the luck of the patient, or the doctor's right decision. And more unruptured aneurysm was treated in many centers, but especially those with a low risk of rupture, such as a small ophthalmic artery aneurysm. Is it right? More and more fluid divert used to treat giant, big aneurysm and even some small or tiny aneurysm. But considerate complication of fluid divert and the complication of the antiplatelet, I think we should be careful to use FD. This is the last slide. For doctors, every patient, every case, we have to make decision. So, to be or not to be, that is the question. Thanks for your attention.
Yes, thank you, Professor Pena. So nice presentation. So finally, the patient had a good outcome. So even this patient suffered a very difficult situation, very difficult condition to treat the relaptured serpentine aneurysm. So he, as Professor mentioned about the interrupt in his presentation. So what is the optimal treatment is very difficult to decide in the actual clinical scene, I think. So finally, the patient had a good course given the difficult situation, even this is a very difficult situation. So we have to consider about patient situation case by case manner, I think. So there is sometimes can be treated by the endovascular treatment, of course, the flow diversion or using the coil without coil, and of course the direct vascular reconstruction using a bypass surgery sometimes. So I think the important point is to occlude the ruptured site, and so how to detect the ruptured site of the entire serpentine aneurysm is a key point. Is to detect the ruptured point, and the next is as you mentioned, the important is timing of the treatment. So at first, the patient non-treated, just observed and followed up in the region. And but the patient luckily that even after the rupture, the patient kept a good condition. So I think that there's many discussion. There's many opinion around the attended. So first with Dr. Ben, please give your question for the audience. Thank you.
Okay.
Yeah,
Thank
thank you.
you for your question. How to make decision of the rupture point, because we before the aneurysm bleeding, we use AI technique to assessment the high risk of this kind of aneurysm, and you can see the sick one. That means the biggest one is the most risk of rupture. So and the sick 2 and the sick 3. So in the embolization, we put the stent and put the microcaster in the distal of the aneurysm in the sick 3 and sick 2. Then withdraw the microcaster to the biggest one to make a package of coils. and use the stenting deployed to reconstructing the channel. So this is how benefit from the AI technique. I think so.
So please wait for Dr. Ben, please wait for your question. So we
Sure.
continue his comment. So this is my first important, as you asked me, important point is the detection of the rupture point. So you used in your presentation for this patient, you just use the AI technique using the like a CFD analysis. So at first my question is this tool is Annual Flow is a commercially available software, really, in the Chinese or
Yeah.
over?
Annual flow is a Chinese AI technique. This company's founder is engineer from the fluid hydemic. He have make research in Buffalo, so he went back to China to establish this company to make some AI assessment in neurovascular, also in cardiovascular.
Great. So using the annual flow, so did you validate the comparison, the actual ruptured point and the AI techniques imply the ruptured point? So I mean, is that accurate detection for the ruptured point using this AI software? I am still wondering about if the AI software annual flow can detect accurately the ruptured point or not. Thank you.
You means unruptured aneurysm or ruptured
sorry.
aneurysm?
In ruptured aneurysm. So detection of the ruptured point using
rupture point. Yeah. For unruptured aneurysm, we use this kind of AI technique to make risk assessment. So it helps us to make decision to decide what kind of unruptured aneurysm to be treated or not to be treated.
Oh yes.
Yeah. So sometimes this AI technique can tell us what is the rupture point of high risk, but sometimes not.
This is the ideal software for the patient with an ruptured aneurysm. Yes.
Yeah. Maybe it can help us. Yeah.
My comment is to detection of the ruptured point in the aneurysm, in the ruptured aneurysm. To use the nowadays we can use the visceral imaging, the MRI, post-gadolinium enhancement. So you think that yes, if you use the gadolinium enhancement, post-gadolinium enhancement of the magnetic resonance imaging using visceral imaging. So sometimes we can detect precisely the ruptured point. So where the entire aneurysm wall. So imprecisely. So when I detect the ruptured point precisely and accurately, so we just occlude only the ruptured point as you presented in your slide. So after that, the remaining part of the aneurysm can be treated later or just observed. It's maybe one treatment option for the serpentine aneurysm. So, but now today you just to demonstrate it successfully as you partially coiled for the only ruptured point. So that's why the patient had a good outcome for this treated patient for the ruptured aneurysm. Thank you. Okay, please.
Thanks for the comment. Yeah.
Thank you. Dr. Ben, give you a comment. Thank you. Thank you for waiting.
No, not at all. Thank you so much. And I'm very interested in this topic actually about those serpentine rhythms and doing I watched some cases from China and also like do some literature review. So I would like to stir up the discussion between maybe Professor Panya or Kimura, Professor Kimura, and also maybe Professor Wali about the management of this type, especially compare open or endovascular technique. So like for open options, so if you have a serpentine MCA or ICA aneurysm, so if there is no perforators coming out from that segment, so you might consider doing a bypass with trapping or interposition graft for reconstructions. Whereas if there is some perforators coming out that you think the bypass of that perforator or branches is not feasible, then I think another option that is described in the literature as the last resort is the proximal, is a bypass plus proximal or distal occlusion. And so usually the proximal occlusion has a higher successful rate and a less bleeding risk. And as you can imagine, because you are occluding the inflow of the aneurysms. But given that in the literature, say for the distal occlusion, so you might have the ischemic complications around like 10%, whereas there is also case report like 5 to 6% of a rupture after bleeding after the distal occlusion. So the one tips or one tricks that I think is useful is what you mentioned just now about to know which part of the aneurysm is prone to bleeding at that moment, and then you add clips to that segment, that you clip that segment partially, whereas you do the distal occlusion. I think that would be the best option in those very, very difficult serpentinous ICA aneurysm, talking about the open technique. So because these are only case series that I search on the literature, they're only case series, I do not look into the endovascular about this. So my question is, as mentioned by Professor Pang in your lectures, like, so what should we do, open or endovasculars? Because you can see endovascular, even in endovascular, you still face the same ischemic, the problem of ischemia. Or sometimes if it's in rupture case, if you put a full diverter, you worry about you give the antiplatelet and the patient will have bleeding. And then this is the dilemma. So maybe I would like to ask about the opinion from the expert, like Professor Pang, like Professor Kimura or Professor Wali. Yeah, thank you so much.
Thank you. Thank you for your questions. Yeah, open surgery clipping for this kind of serpentine aneurysm or a long dissection aneurysm, I think it's very difficult to cure it. Partially clipping 100% due to recanalization. So maybe and embolization is the good choice. But this case of aneurysm, the point is three important perforating artery from the body. So this is difficult. But I think maybe two-stage surgery maybe is a choice. Bypass first, ECA to M2 to establish the collaterals. Then 3 months later, clipping the clinoid of the ICA. maybe the collateral was established. I don't think, but the patient was very lucky, recovered very well from bleeding and from infection. So I think maybe this is the very important reason for a good outcome. Yeah.
Yes.
Thank you. Thank you, Dr. Professor Ben. So, can I give you my comment for this case?
Yeah, please.
Yeah, so staged surgery is a good option to treat the difficult, challenging region. So I think not in acute phase, we do not do the bypass surgery. Just occlude the ruptured point that using the endovascular technique, like partial coiling or sometimes we need to, of course, with the stenting sometimes. But antiplatelet drug do not work sufficiently in acute phase, just using a coiling, if possible, ruptured point. So in a chronic phase, maybe the aneurysm sometimes enlarged or the parent artery sometimes stenotic due to the coiling. So in that situation, we have to give the bypass surgery for the distal MCA. In sometimes some situation we have to perform the high flow bypass, or sometimes we just perform the double barrel low flow bypass, and it's just depending on the patient condition, and with proximal occlusion, and sometimes of course the trapping of the lesion. So this is a ruptured case. So my opinion is that for the ruptured aneurysm should be trapped, not proximal occlusion. Just we need to trapped, and entirely this proximal and distal also should be trapped to avoid the rupture. So in the case after coiling, the aneurysm enlarged, not ruptured, but even in for the enlarged, we have to do the trapping with a bypass surgery for the distal MCA region. So of course the postoperative small LSA region infraction or some infraction occur, but to give a good option, better surgical result is just to do the bypass with trapping, maybe a good option for the patient, I think. Thank you. Okay. Is there any comment or question for the audience? Professor, now, do you have any other case like this happened in aneurysm, even for the unruptured one, or some another ruptured case? Do you have another? Because you have so many cases in your hospital, like complicated and difficult cases, I think. So if you have, please tell us. Thank you. Professor Payne? Yeah, okay.
Just sorry, can I ask maybe a last question about for the analysis of that AI with the CFD as shown in your PowerPoint. So is that readily available in China, or for that kind of the software to analyze the hemodynamics of the aneurysms?
You means the AI technology?
Yeah, the annual flow.
Yeah, Aneurysms. Yeah, is a Chinese company. This software is to give us assessment of rupture risk by wall shear stress and oscillatory shear index, and using the hemodynamics and morphology. So it's very useful to assessment the risk of the unruptured aneurysm.
I see. Thank you so much.
This software is complimentary or expensive?
We use this software in our DSA. Yeah.
Okay. So how about like CTA or MRA? Is there also okay for them?
No, just angiography.
Angiography.
Oh, just
Yeah.
I see.
Yeah. I can understand why Dr. Ben asked.
Yeah,
this,
I can understand.
but
I know Professor
we have-
Kimura understands. Yeah.
Yes. That's,
Yeah,
we are
maybe-
searching about
Yeah,
good.
yeah.
Yeah.
Maybe
Yeah,
in
we
the future, maybe to learn from Professor Kimura or Professor Pang about like how to do this kind of the analysis, and in the future. Yeah, thank you so much.
Okay, and one more question from the audience here. Dr. Harshad, do you have a comment question? Dr. Harshad? Thank you.
You can see now. Yeah, Dr. Fascial.
Hello, Professor. Excellent talk, which was very nicely demonstrated. In the presence of era of endovascular treatment and this flow diverters available now, do we really need to go for all these complex surgeries? What is your comment?
You just use the flow diverter for this region?
Yeah, flow diverter or any other stent assisted coiling. For this kind of a endovascular treatment is now available, and various speakers have given a very good review about it. So do we go for such a complex surgery? What is your view?
Yes, for many giant or big aneurysm, flow divert is a good choice. But for this case, depend on the length and tortuosity and the angle of the vessel and the diameter of the distal of the proximal of the vessel. I think flow divert application is very tough.
Okay, thank you. Thank you very much.
Thank you. Thank you for your question. So if any other comment or question from the audience, if any, no. So now we wrap up this session here now. Okay. So Dr. Ben, please, yeah. Okay, closing remarks or something like that. Thank you.
Sure. Thank you so much. So it is indeed a very rewarding night with two eminent speakers talking about the first section is with the endoscopic suturing technique, very advanced suturing techniques. And I would like to thank you, the chair and the speaker of today, and about this technique. And also for the second section, we encounter a very difficult aneurysm. And I think this is the most difficult type of the aneurysm to be treated in the reality. So I think luckily we have so many experts here, and that we can discuss about the endovascular arm, the surgical arms, and we learn so much, and we reflect so much from this case. And I would like to thank the chair and also the speaker of the second session as well. So it's the time to say goodbye, and it's the time for the final remark. So on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Professor Masahiro Tosaka and Professor Panya, as well as the chair, Professor Julius, and also Professor Kimura for the time and the effort for the ACNS webinar. A special thanks to Professor Xu for broadcasting this webinar on WeChat channel, and special thanks to my co-host, Professor Liu Bun Singh, for joining me today. Until we meet online tomorrow, it's a bye-bye from all of us. And thank you so much for joining. And indeed, very rewarding night. Thank you so much.